hoping that everyone is keeping well. There's a lot of turmoil in all parts of the world right now. And so I hope everyone is keeping safe and as well as possible. I'm going to talk to you about a topic that I really think a lot about and I think is fascinating, which is infant hydrocephalus, but specifically the role of endoscopy versus shunt and what we know about these two procedures specific to infant hydrocephalus. I have no specific conflicts of interest with respect to this talk. And I'm going to try to answer three broad questions. So one, what is infant hydrocephalus? And I'll deal with that very quickly. Number two, is ETV, endoscopic ventriculostomy, actually better than shunt in infants? And what the data is to support or refute that. And then is choroid plexus cauterization a game changer? Does this change the equation of ETV versus shunt for infant hydrocephalus? And I'll begin with this because, what is infant hydrocephalus? And it's an obvious question with an obvious answer, except that when I speak to an international audience, I have to keep in mind that what we see as infant hydrocephalus is very geographically specific. And so I'm going to speak mostly to what we see in North America. And that may or may not apply to the patients that are seen in other parts of the world. And so when I speak of infant hydrocephalus, this is data from the Hydrocephalus Clinical Research Network showing all the infants under 2 years of age with hydrocephalus that we treat. And you'll notice two things. First, that the big population groups for us are myelomeningocele and intraventricular hemorrhage of prematurity. And then a smaller group is aqueductal stenosis. So these are the big two. And then if you add aqueductal stenosis, that's the big three. The other thing to notice is that even if you consider infants to be under 18 months or under 2 years, the vast majority of those who present with hydrocephalus and get treatment are actually under 6 months. So, and you'll see that the majority of them currently, this is how we treat them. So I'm going to talk to you about ETV versus shunt, but the fact of the matter is, at least in North American practice, the vast majority of these infants are treated with shunt right now. We still do ETV in a reasonable number of these patients, but it's a minority, okay? So I put that here because for me, when I answer this question, what is infant hydrocephalus? For me, it means very young babies who are under 6 months of age when they present, who have myelomeningocele or intraventricular hemorrhage of prematurity and are predominantly treated by shunt. That to me is infant hydrocephalus in my practice, okay? And that may or may not apply to you to varying degrees, depending on the population that you're treating. But with that as a starting point, let's ask this important question. Is ETV actually better than shunt in infants? And this is very hard. So I'll tell you right now, I'm not going to have a clear answer for this, as you might have guessed. There's nuances to this question. Part of it is deciding what outcomes you're going to consider. And one of the outcomes is, of course, surgical failure and the need for repeat surgery. That's a clearly very important outcome, one that we have spent a lot of time in neurosurgery looking at. But the other important one is quality of life, which in a way I think is more important. And I'll talk about why in a second. But let's start with surgical failure and the need for repeat surgery, because that's pretty easy to measure. But even though it's easy to measure, surgical failure data comparing ETV to shunt in infants is still quite sparse. We don't have a ton of this data available. This is data that we put together from multiple centers. And this is not infant hydrocephalus. This is all age groups. This is non-randomized data. So this was data collected from multiple centers across the world in patients who were not randomized to shunt or ETV. This is non-randomized data, and again, involving patients of all age groups. And if you look at it, it suggests that there's not a huge difference between these two procedures. You have ETV maybe failing a little earlier, more frequently, but then it levels off a bit, and by about 3 years, it suggests that they're not all that different. And maybe you can conclude from a surgical failure perspective, there's really not a big difference. But the problem is what I've shown you here is an artificially balanced cohort. We used a technique to balance the risk factors for this group of patients. So what we're having is an artificial cohort that doesn't represent any particular patient. It represents a general average. And in fact, it involves mostly older patients. There are very few infants in this data that I'm showing you. So it doesn't really help us answer that question about infant hydrocephalus. So we can look at it a different way. We can stratify that data. And how do we stratify that data? Well, we can use the ETV success score. And so the ETV success score is something that we published many years ago now, but what it does is it gives a score based on age, going from 0 to 50, based on etiology from 0 to 30, and the presence of a previous shunt, either 0 or 10, and you add those 3 scores up, and you get a score from 0 to 90. And that gives a rough approximation of your percentage chance of ETV success. So a 5-year-old with aqueductal stenosis, who I think most of us would agree would have a high chance of ETV success, this score bears this out. They have a score of 80, so about an 80% chance of success, whereas a 2-month-old with post-infectious hydrocephalus only has about a 20% chance. So we can take a large population and very easily give them an ETV success score and then stratify the data that I showed you by this ETV success score to get a better sense of how patients do within these different strata. So here is the strata of patients who all have a high ETV success score. So these are patients who we expect to do well with ETV, but when we take the same data that I showed you and show you this group of patients, some of whom had an ETV, but some of whom actually got a shunt. So even though they were good ETV candidates, for whatever reason, their surgeons treated them with a shunt. So we have that data, and we can compare these two groups. And what you see is ETV actually does look better here, right? This is actually fairly convincing data. It's not statistically significant, but at worst, it's maybe about equal to shunt, if not better. That's great. The problem is this doesn't go to our original questions because there's virtually no infants in this group. There's very few infants who have an ETV success score of greater than 80. So this is, again, a different population. These are typically older children or teenagers with aqueductal stenosis or tectal tumors, right, who we know will do well with an ETV. Then we go to the moderate group of patients. So these are patients who we would predict to have about a 50 to 70% chance of ETV success. And if we compare this group of patients, you can see that if that group gets a shunt, they actually do a little bit better early on, but by about 2 years, there's really not much of a difference between them in terms of surgical failure. Okay, and again, not statistically significant. Here now, there's a few infants in this group, but not a lot still, because this is the group we care about. This is where the majority of our infant population, at least in what we would see in North America, sits. These are infants who have an ETV success score of 40 or less. Okay, and here we actually do see a difference, and it's not good for ETV. Here it is statistically significantly different, and what you see is that there's a large failure rate early on. You can see how quickly this curve drops off. So you do an ETV, and very quickly a large group of these infants, almost 40%, fail right away. And then even after that, there's a slower failure rate before it eventually stabilizes. But by that point, so many fewer shunts have failed that there still is a statistically significant difference, and shunt does better than ETV for this group of patients. So that doesn't look good, right? If we ask the question again about shunt versus ETV in infants, this is not looking good for ETV. And you can look at that another way. This is some of the data that I showed you before. This is all age groups, ETV versus shunt. But if we, instead of breaking it down by ETV success score, if we break it down by age, what you see, so again, here it looks actually very good for ETV when you have all the age groups combined. But when you break it down to infants, so just under 2 years, it doesn't look so good now. It's not bad, right? So by about 2 years, it looks like things even out. But early on, shunt clearly looks better than ETV. So under 2 years, that's our infant age group. But remember what I told you, the majority of the infants that I see with hydrocephalus are actually under 6 months. And so here's that same data now of those who are under 6 months. And it looks, again, not very good for ETV. Looks worse than what we saw before and not unexpected. And here you have at 12 months, you have what we call an absolute risk reduction of 22%. That equates us to what we call a number needed to treat of 5. And what that means is that for every 5 shunts you perform on these kids, instead of doing an ETV, you will save one infant an extra failure, okay? Conversely, it means that for every 5 ETVs that you do, there'll be one extra surgical failure because of that. Okay, so that's an important number to keep in mind, that 22% difference in ETV versus shunt success rate in those under 6 months of age. Now, again, that's a broad swath, right? I just broadly said infants under 6 months, and we see what they do. But that we can be more nuanced about that. Can we identify a more favorable subgroup that maybe do better with ETV? And here is where I'll turn to data from another study that we did, which is the International Infant Hydrocephalus Study. This was a large, prospective, multi-center international study run across the world comparing ETV versus shunt for infants under 24 months of age who had a pure aqueductal stenosis. Okay, so no major other brain anomalies, no myelomeningocele, no prematurity, nothing else funny, only aqueductal stenosis. So it's not a big group of patients. So it makes up about 15–20% of the patients that I would see. But you know, it's an interesting group to study because it's a very discrete type of hydrocephalus. And if we look at all that data, so this is for all the patients under 2 years of age, what we see is that there's an absolute, that shunt does look a little bit better, okay? An absolute risk reduction of 15% for all patients under 2 years. But here's something really very interesting. You know, under 6 months of age, look what happens. It's the same data, very similar to the data I showed you before. This is totally different data. Remember, I told you to remember that 22% for under 6 months of age? Here again, in a completely different study, we're also showing 22% at under 6 months of age. That's you rarely see that, but you know that type of validation of data. But here we go, we saw it here. But look what happens if you look at over 6 months of age, right? So now ETV is doing tremendously well, 80% success rate. That's great. So again, I take you back. This is you can lose some of the real interpretation when you look at a bigger group. So just under 2 years, again, I'm showing you this again, but really what it is two separate groups, those under 6 months who don't do well, and those over 6 months and still under 2 years, right, who do very well with ETV. So that's really important data. So, you know, to answer that question, is ETV actually better than shunt in infants? Well, first, as with respect to surgical failure, overall, the answer is no. They generally do worse. But we can define at least one limited subgroup where they may do at least as well as shunt, which is those who are with pure aqueductal stenosis between 6 months to 2 years of age. Okay, so that's something to think about. But you know what I think is more important than looking at survival curves and surgical failure is this, which is quality of life. And quality of life, you know, is how the patient and their family feel about how they're able to live their lives. And why I think this is important is because there's so many things that impact the child's life, right? We do the surgery and there could be complications from the surgery. They could have repeated failures. And so they're in hospital a lot. They don't go to school. They don't have as many friends. The family is always concerned and anxious. They don't travel as much. All these things impact how much of a normal life these kids can lead, right? And so this is why I think quality of life is really the most important outcome that we should be considering. And I won't go into a lot of the detail on these studies, but just suffice to say, we've done a number of large retrospective studies here in Toronto and across Canada. And the basic summary of them is that there is not an obvious quality of life benefit to ETV compared to shunt. All right, that may go against what we think, right? Intuitively, we think ETVs, you know, if it works, is a better procedure, right? And we would expect that there would be a better quality. There isn't, and I'll talk about that near the end about why we think that, and we're wrong to think that. So understand, no obvious quality of life difference between ETV and shunt. That's retrospective data on a large group of patients with multiple etiologies. But we can go back to that international infant hydrocephalus study that I just showed you, which is the pure aqueductal stenosis group. We had 158 patients. This was a non-randomized study. And we had 59 patients who were available for 5-year analysis with ETV and 19 who had shunt. So this study was meant to be randomized, but we couldn't randomize enough patients. So it ended up being a non-randomized study, but it was still prospective and longitudinal. So there's still a tremendous amount of really good data here, because what we did was we treated these patients when they were infants, you know, about 1 to 2 years of age, and then we followed them every year until they got to 5 years of age. So very powerful data, which is really still very unique. And what it shows is what I showed you from the retrospective studies, which is that there was no significant quality of life difference with any of these scores comparing ETV to shunt. You can see the scores here are very similar. A couple of things about this data, though. One is that the quality of life scores were very high for both ETV and shunt. And that's because this was pure aqueductal stenosis in infants. So they do very well. These scores that I'm showing you are not that different from the general population. So these are kids on average who look like and act like and are living like regular children, okay, that you couldn't tell them from the general population. The other thing that we noticed was here, though, there was a difference in the cognitive score. Now, this wasn't statistically significant, all right? So I don't want to make too much of this, but we noticed that, that difference of 0.1 is larger than we saw for any other score. And so we did look at that a little bit further, because one of the concerns with ETV is that your ventricles remain large. And so we looked at the issue of ventricle size. And of course, ventricle size was larger in the ETV group versus shunt, but that didn't change any of our outcomes, even after we adjusted for that. And ventricle size was not a significant predictor of the 5-year outcome. But, it's something that we do think about. Now, it's good. This is good data, but again, I remind you, it's not randomized data. It was a relatively small sample, and it was limited to, as I said, higher functioning children. So this may not apply to the kids with myelomeningocele, with post-infectious hydrocephalus, or hydrocephalus associated with prematurity in that. So, and as well, this was an intention to treat analysis. So it only speaks to the initial choice of treatment. There were some patients who I've shown you in the ETV group who failed their ETV and then went on to have a shunt, right? But, and I didn't account for that here, all right? So keep that in mind. There is one area of quality. So far what I've told you is that there is no difference in quality of life between ETV and shunt. There is one area, though, where ETV does have a lower level of parental concern compared to shunt, right? So that's a quality of life metric, right? How concerned, how anxious are the parents of these children with hydrocephalus? And with ETV, they have less concern, less anxiety. And in general, we would say, oh, that's a good thing. That's a positive sign. It's a double-edged sword, though, because I think lower parental concern can have its own danger. Jim Drake has shown us, and I think each of us in our practice have had this anecdotal experience of people who've had ETV and then many years later present with a sudden deterioration. And oftentimes, as you can see from this chart here, they die as a result of that. And if you look back at the history of these patients, you often get the story that, yeah, they kind of had headaches for a few days and they vomited a bit. And then we thought they would just sleep it off. And then they go to bed one night and they don't wake up the next morning because they've died. And, and sometimes it's because these families, oh, they have an ETV, they're cured. We don't have to worry about hydrocephalus anymore. The kinds of symptoms that a shunt family would never ignore, right? They would have brought that child right to the emergency department. So yes, it's good that parents are less concerned, but you have to be careful. I think a certain degree of concern and vigilance is important to avoid potentially preventable things like this. So to answer the question about quality of life, is ETV actually better than shunt with respect to quality of life? I think, again, the answer is probably not. I think they're very similar. So this brings us to the question of ETV-CPC. And this is, again, a regional thing. And I don't know how often and how popular it is in various parts of the world. I'll tell you a bit about how it's being used in North America. But the history of this is interesting, right? So we know that as you go back over 100 years in the hydrocephalus literature, choroid plexus was often the target of hydrocephalus treatment, whether it was coagulating the choroid plexus or actually trying to surgically remove the choroid plexus. This is what people were doing, the big names in neurosurgery like Dandy and that were doing 100 years ago. And that continued into the early part of the last century. But they were very limited in terms of their anesthetic technique and the equipment that they had. And you can see here some of the results from the 1940s. Look at this, almost a 40 to 50% intraoperative mortality, right? Terrible procedure. But they didn't have much else then. Of course, shunts came along in the latter half of the last century. And once shunts came, almost nobody did choroid plexus cauterization or targeted the choroid plexus for hydrocephalus. There were a few niche centers that continued to do that for a few patients, but really shunts was the treatment. And then things changed a bit in 2005 when Ben Worf published the work that he did in Mbale, Uganda, where he had a technique because he was having difficulty obtaining shunts in the setting that he was at, that he used a flexible endoscope and a single unilateral coronal entry site to do an ETV and then access both ventricles through a septum pellucidotomy to cauterize the choroid plexus of both lateral ventricles, again, through a unilateral coronal approach. And he published this very large series in 2005. And this is what choroid plexus cauterization looks like through a flexible endoscope. And again, I apologize. You may do this a lot, and so I don't mean to insult you by showing this, but this is what it looks like. You know, you just it's technically not that difficult a procedure. It's a bit tedious as you have to work along and slowly cauterize this this choroid plexus. This is what it looks like after it's all done. That we're in the left lateral ventricle here. And this is the blanched choroid plexus of the left lateral ventricle. And then we've created a septum pellucidotomy, and then we're going over to the contralateral side. And so now you'll see into the right lateral ventricle, the blanched choroid, this is already completed. So this was the blanched choroid plexus of the right lateral ventricle. So that's what you aim to do. And you actually take the endoscope into the temporal horns as well on both sides. And because it's a flexible endoscope, you're able to do that. So that's what you try to do. You do the ETV and then you do this. And what he showed in Uganda was that adding CPC, okay, to the ETV improves your chances of overall success in all ranges of hydrocephalus etiologies, in myelomeningocele and post-infectious hydrocephalus, but also in congenital idiopathic hydrocephalus and congenital aqueductal stenosis as well. He also showed that there was what I call a dose response effect. And this is when you know, I helped him do this part of the analysis. And this is when I started to become convinced that maybe there's something real with this procedure, because what he found, what the data showed, was that doing a partial choroid plexus cauterization improved your chances of success compared to doing no choroid plexus cauterization, but doing a complete choroid plexus cauterization improved your success even more than a partial choroid plexus cauterization. So to me, that suggested maybe biologically there's something real there. Now, of course, there could be a number of other confounding factors, but that's when I started to become curious that maybe there was something real to this procedure. He also showed other data in a small sample of myelomeningocele patients that there was no difference in early neurocognitive outcome, and that there was likely no benefit or harm to the survival of a subsequently implanted shunt. So that if you do this procedure and then you have to put in a shunt later because it fails, that shunt that you put in doesn't fail at any greater rate or lesser rate compared to the shunt that you would have put in early on, okay? And eventually we did a randomized trial in Uganda because we identified that there was a group of patients with post-infectious hydrocephalus. So this is a very specific group, post-infectious hydrocephalus in Uganda, which is we don't see this type of patient in Toronto or North America, okay? So it's very unique to that and similar parts of the world. But we did a randomized trial in infants with post-infectious hydrocephalus in Uganda. We found, you know, no difference in the 12-month outcome. And this is the survival curve, no difference in, even though a slight suggested difference in failure rate, it was not statistically significant. This was a trial that looked at patients who were only under 6 months of age with post-infectious hydrocephalus, and they were randomized to ETV-CPC or ventriculoperitoneal shunt. We randomized 100 patients, and for the 1-year outcome, we had 47 patients in each arm who were available for 1-year analysis. And what we found is this is the Bailey score of cognitive development, so a very standard score for infant cognitive development. And this showed no difference in outcome and no difference when we adjusted for age at randomization or baseline scores, no difference based on whether it was intention to treat or treatment as received, no difference in any of the other Bailey scores, and no difference in changes from baseline. So very similar is what I'm trying to say. Where we did find a difference, not unexpectedly, is that the ventricles were smaller in the shunted patients than the ETV patients. Okay, that's not unexpected, right? We know that ETV keeps the ventricles much larger than with the shunt. But here's what's interesting. We looked at brain volume as well. And we found that even though the ETV-CPC patients had larger ventricles and more CSF, there was not a significant difference in their brain volume compared to the shunt patients. So basically their heads grew larger to accommodate for both the increased CSF, but also for the brain volume, okay? So from a brain growth perspective, it didn't make a difference. And that proved to be important. Why I put that there is because this is one of the post hoc analyses that we did, but that I was very fascinated by. We found the brain volume was actually important to cognitive outcome in this population. Those who had a normal, so a lot of these patients had started with subnormal, lower than normal brain volumes because of their infection and stuff. But after we treated them, those who got a normal brain volume had higher cognitive scores. Those who showed substantial growth in their brain volume in the time of treatment, they had higher improvements in scores. And there was a positive correlation between brain volume and cognitive score. So you higher your brain volume, that correlated with a higher cognitive score. And importantly, we did not see this with CSF volume. So we didn't see a negative correlation of cognitive scores with CSF volume. It was just brain volume. And you can see, illustrative examples here. On the top panel are patients who went from subnormal brain volume to normal brain volume. So they increase their brain volume in a way that we like to see. And that can happen with shunt, as I show you in the top left, or it can happen with ETV-CPC, as I show you in the top right. Even though the ventricles are still large, this patient had a significant improvement in their brain volume and did well, as opposed to these patients in the bottom panel who did not improve their brain volume, and they remained with abnormally low brain volumes, and they both did poorly, even though this one got a shunt and this one had ETV-CPC. Okay, so that was an important finding. And then we've been following this patient group even longer. So the 2-year results are out. We unfortunately, because of the circumstances that these children live in sub-Saharan Africa is quite unfortunate. And so 6 of them died from infectious causes unrelated to hydrocephalus. 3 of them died from malnutrition unrelated to hydrocephalus, right? So only 2 deaths were hydrocephalus related. So we had 89 patients available for the 2-year analysis, and basically the results were the same. Okay, the survival curves look the same. And again, we saw the same correlation with brain volume, with cognitive outcome, and not CSF volume, just like we did at the 1-year outcome. So great results. The sad thing that we saw, though, was that in that 2nd year of follow-up, their brains, for a lot of these patients, seemed to stop growing. They sort of had a stagnated growth in that 2nd year. And we don't know why. We don't know why that is. And it could be because, again, remember, these are post-infectious hydrocephalus, and this could be a downstream effect of the initial infection and inflammatory response. It may be that they have an unrecognized indolent brain infection that's preventing further growth, or it could be just that the unfortunate circumstances of things that are prevalent in that population that they have to deal with, like malnutrition, that impacts their brain growth. We don't know, and we're investigating that further. So we are continuing to follow this cohort to 5 years, and now actually we just got funding to follow it to 10 years. We are using ultra low field MRI to better study their brains. We did not have that in Uganda before. And we're also, as I'll tell you about later, we're conducting this very same study in North America to give us a different population, and we'll see what happens with their brain volume. And I'll talk about that towards the end. So let's talk about North America now. And I apologize again, every time I give a talk like this to an international audience, I apologize for the fact that this is very North American centric. And the reason that it is of course, because this is what I'm most familiar with for my practice, but also a lot of the work on ETV-CPC that's done outside of Africa has tended to be North America. And from what I hear anecdotally, it has not caught on much in Europe as a prevalent procedure. I don't know in Turkey and other parts of the world whether people are doing this or not, but a lot of the interest outside of Africa comes from North America. So that's what I'm presenting to you here. So Ben Wharf, who originated this procedure in Uganda, has since been in practice in Boston for many years now. And this is his most recent results from Boston, where he had 215 patients under 2 years of age in whom he performed an ETV-CPC. And the population, again, remember I started by showing you, is just like what I said: myelomeningocele, premature, interventricular hemorrhage of prematurity, and aqueductal stenosis, just like what I see. And what he found that was that the predictors of failure of ETV-CPC is very young age. So if they were under 4 months old, they didn't do as well. If they had a prior history of CSF diversion, just like what we showed with the original ETV success score, so having a previous shunt was a poor prognostic factor, and having a lower Uganda score. So this is the Uganda score. This was just like the ETV success score, this was like the Uganda ETV-CPC success score that tried to predict outcome. And so as expected, a lower score here meant a lower chance of success, as we would expect. His data otherwise, though, was pretty good. So if you look at the solid blue line, what he's showing is that in his population of 200 infants, only about half of them ever need reoperation. So he does the surgery and only 50% need reoperation. And when he reoperates on them, he's able to salvage some of them so that he does ETV again. And by the end of it, only 30% need a shunt. Okay. So that's really good data. And that looks a lot better than the shunt data that he's showing here. So his data is very promising, right? The thing is, though, we haven't, not all groups have had that similar success. So the Miami group is another group that's done a lot of ETV-CPC for quite some time. They use a different technique. So they use a rigid endoscope, whereas Dr. Worf, as I showed you, uses a flexible endoscope. So with the rigid endoscope, they're able to do a little less choroid plexus cauterization because you aren't able to get into the temporal horns. But you can see here, their curve, they have an overall about 40% success rate. So it does not look nearly as good as Dr. Worf's does. And why is that? So we did look at that data. We compared the Boston and Miami experience, which was basically comparing flexible endoscopy to rigid endoscopy. And you can see here, flexible endoscopy does better, right? Higher success rate. But this is really Ben Worf versus Miami is what we're talking about here. And so if you do the unadjusted analysis, the Ben Worf series, the flexible series does much better. So the odds of failure with the rigid endoscope are about 60% worse. But once you adjust for patient factors like age, sex, etiology, prior CSF diversion, and whether they have what we call pre-pontine scarring, once you adjust for those, there's no difference between the groups. So in fact, it may not be a difference in technique. It may not be that Miami is just worse at doing this procedure than Dr. Worf. It may be that a lot of it is because the patients they're selecting to do this on are patients who are at higher risk anyway. And they had a higher chance of failure, even if Dr. Worf did the surgery. Okay, that's what this data is showing. Now, the other major group that's been doing this is our research group. So this is the Hydrocephalus Clinical Research Network, the HCRN. This is multiple centers across North America. Toronto Sick Kids is part of that group. And as a group, you can see here that we weren't doing much ETV-CPC until 2013. And what happened in 2013 is that a number of us that year, because we became interested in this procedure, went to Uganda, went to the center that Ben Worf was at. And we spent a week or two there and learned the procedure from them. And then we brought that expertise back to our home centers and then started doing, 80 to 100 of these cases per year. So we do a lot of these now across the HCRN. And we did a prospective study early on to see what was our data like? How was it comparing to Ben Worf? And we did a study of 118 patients. You can see that, again, it represents a very young group. So the vast majority were under 6 months of age. Their ETV success score was not very good. So 30 to 50% success rate, mostly under 40 or under, I should say, just like we expect in an infant group. We want to get, remember the goal of CPC is to cauterize all the visible choroid plexus. And we were only able to do that in 75% of these patients. And I highlight that because Dr. Worf is able to do that in almost 100% of his patients. And the reason for this is that this is the early experience in our series. So this is just us having gone to Uganda, coming back, and we're starting to do this procedure now. So we weren't great at it. We were not as good as Ben Worf at doing this procedure. So we were only able to achieve complete choroid plexus cauterization 75% of the time. That number is higher now. I've done many more of these procedures now. I feel much more comfortable with it. And, I think my number there is well over 90% now. But it wasn't in this early series, right? I was still learning. And these are some of the complications that we had. And none of these are particularly surprising. What I'm a little bit concerned about is this, that the seizure incidence is 5%. And that worries me. And the reason that worries me is that from the quality of life data that we've done, one of the most important predictors of quality of life in children with hydrocephalus is the presence of epilepsy. So if they have seizures, a history of seizures, their quality of life is automatically significantly worse. And so to get a 5% rate like this worries me. Now, in the cases that I've seen this, anecdotally, the seizures are self-resolving. So they tend to be on phenobarb or Keppra for a few months, but then they don't have any further seizures and they're weaned off and they seem to do well. But I worry about that because could these seizures recur when they're older and impair their quality of life? Okay, so I think that's something we have to keep in mind here. But here are our results, and they look a lot like Miami, right? If you remember the Miami curve, it looks very similar to this with a success rate of around just under 40%. And our predictors of success in this group were, again, young age was a bad prognostic factor. Having larger ventricles was a bad prognostic factor. How much choroid plexus was cauterized was important. So again, the fact that we didn't cauterize the choroid plexus in all the cases, that means our results would be expected to be poor. And then what we call visualization of a naked basilar artery, which means that we were able to not just create a hole in the floor of the third ventricle, but clear away any arachnoid adhesion so that there was a clear pathway for the CSF. If you're not able to do that, then your chance of success is very low. And when we compare it to a historical cohort of shunt, it still doesn't look good. ETV-CPC looks quite a bit worse than shunt, okay? But again, I hold the caveat that this is, we were doing this for a lot of different patients. I think our criteria for this procedure is more refined now, and I think we're better technically at this procedure than we were when this data was analyzed. So I think right now we're at a stage where the role of ETV-CPC in children, especially in North America, is still evolving, and there's a lot to learn, and we're still defining what the appropriate indications are. So these are, what I've listed here are very loose indications. So this is not the gospel. This is not exactly how we do things. We change things here and there. But in general, the patients that we consider for ETV-CPC are like myelomeningocele patients who are term age or above, those who have intraventricular hemorrhage or prematurity, but are over 3 or 6 months of corrected age, right? That's a rare population because usually you will have treated them well before they get to 3 or 6 months of corrected age, right? Which is often 9 months of actual age. So we don't do this often in premature intraventricular hemorrhage. Most other patients, I would consider ETV-CPC when they're at least a month of age because the success rate is higher after they get to a month of corrected age. But of course, they also have to have a favorable third ventricular anatomy and no obvious adhesions in the prepontine cistern. So that's important. I look very carefully at the CIS or Fiesta images in sagittal plane to make sure that in that prepontine area it looks open and doesn't have a lot of scar tissue there. So major questions for ETV-CPC, there's a lot, right? But one of them is there a minimum age at which the success rate is too low to do this procedure? I think that varies based on the etiology. Are there certain etiologies for which this should not be considered at all? And post-infectious hydrocephalus might be one of them because the success rate is quite low. On the flip side, are there other etiologies where adding CPC doesn't give you much benefit? Because CPC adds time to the procedure. I think it adds risk to the procedure. So are there groups where you shouldn't do it because it's not adding enough benefit for the risks? And one might say older infants with aqueductal stenosis, because I showed you that the data from that looks very good. So maybe we don't need to do CPC on those, that ETV alone is good enough. And then those who are, I think that the bigger issue is how low a success rate are parents willing to tolerate for the possibility of shunt freedom, okay? I can tell families all I want that, oh, the success rate of this procedure is so low, we shouldn't do it. And they'll say, I know the success rate is 20% or 30%, but I've heard horrible things about shunt, and we still want the endoscopic procedure, okay? And I don't know what to say. That's a hard discussion to have. And we're hoping to get better data on this. So we're doing a large multi-center study here in North America, where it's funded by the National Institutes of Health. It's a 7-year study where we're comparing ETV-CPC to shunt in a large group of infants who are under 24 months of age. The primary outcome, so again, the primary outcome is cognitive outcome here. We will be looking at surgical failure. We will be looking at quality of life. We will be looking at MRI, CSF biomarkers, a number of really important outcomes, but cognitive outcome is the primary outcome. And we've started recruitment for this. We've been slowed because of COVID, but we've had 29 patients randomized to date with a target goal of 170 patients. So finally, is ETV-CPC a game changer? I think, we don't really know, but I think it might be for a subgroup of infants. And I think the data that we get from our randomized trial will bear that out. I want to end with just one final quick thing. Every time I give a talk on ETV versus shunt, I do have to mention this, which is, I think as surgeons, we have an inherent bias towards ETV, right? And why is that? Well, as neurosurgeons, I think we all agree, everything else being equal, if we're in the OR, we'd rather do an ETV than a shunt. It's a funner operation to do. It's more appealing to us. So I think there's that. And also when we think of shunt, automatically we sometimes psychologically just think about these shunt disaster patients that we have living in our memory who had multiple shunt infections and all these problems with their abdomen and all of this, and were in hospital for weeks and months at a time. We remember them well. We don't have many ETV disaster patients to think about, because what happens when an ETV fails is we maybe give ETV one more try, but then we go to shunt. really, right? Shunt is a salvage procedure. So imagine if every time you did an ETV, if it failed, all you could do was do another ETV. We'd be doing a lot of ETVs, and we'd be starting to hate ETV not too long, right? Because you'd be doing them in the middle of the night on all these patients who are failing. So, but we don't. What happens is we shunt them, and if you look at it, they have the potential to become shunt disasters. But realistically, if you look at all infants with hydrocephalus, only a small number do we treat with ETV. And yes, some of them are successes, and that's great, but a lot of them fail, and then they go to shunt. And then, of course, some of them fail, and then we remember the disasters of them that we have so many. We don't have that many of them, but we remember them because they have affected us psychologically. But what we don't ignore is that there's a huge number of patients who are actually doing very well with shunt and leading great lives, and there's a large proportion, and this is the largest proportion of this whole group. The largest proportion is those who are successful in doing well with the shunt, but we don't often think about that. So this doesn't change our thinking. It shouldn't, but what it does is whenever I'm thinking about deciding between ETV and shunt in this population, I always try to recognize my own biases and just make sure that I'm not giving unfair advantage to ETV in my decision making. And with that, I will end and thank you again for your time, and happy to take some questions.
Sir, thank you for the great lecture. Can you stop screen sharing?
Yeah.
Thank you.
Okay.
Dr. Harshad Parekh, regards from Dr. Harshad Parekh from Mumbai, India.
Very good. Thank you very much.
And Efecan, I want to hear Soner Duru's comments, please.
Okay.
Thank you, Dr. Kulkarni. Wonderful presentation. So, of course, the very challenging situation, very huge topic, hydrocephalus. So, I study especially this in utero the treatments. So, about the research projects and children hospital fetal care. So of course, this method is very important, but also is important also timing for especially the early onset hydrocephalus. What do you think about early onset? For example, second trimester, because we know in 2 or 3 weeks, maybe the irreversible changes the start in the brain.
Yeah.
Thank you.
That's a great question, and so. When you're talking about in utero diagnosis, yes, we obviously make a lot of in utero diagnoses of hydrocephalus. We are not been doing in utero treatment of hydrocephalus. I mean, we do in utero treatment of myelomeningocele, but we haven't directly treated hydrocephalus in utero. And so I can't directly answer your question as to what the impact of brain development is. I think the closest analogy we have is premature infants, right, who are born and develop hydrocephalus, and we can sort of maybe extrapolate that and say, their brains are in the same stage of development as we see in utero. Obviously, there's a number of other confounding factors with that. And in that group of patients, I have become more convinced about the utility of earlier treatment. We used to, here at Sick Kids, we used to be very conservative with hydrocephalus treatment in premature infants and delay treatment by quite a bit, because of the risks of doing surgery in a very young, small, premature infant. And we're still conscious of those risks, but we are treating significantly earlier now in the course of this of the disease in premature infants, and I've been happier with that, because I think you're right. There is impact on brain development by whether it's the large ventricles or in the case of intraventricular hemorrhage, the byproducts of the blood itself. Something's going on there that I think earlier treatment might have some positive impact and might outweigh the risks of earlier treatment. I don't know whether that translates into in utero treatment, because the risk profile for in utero treatment is different. And I don't have personal experience with it, but to me, it's a riskier operation. And I don't know whether the benefits of that are the same. and worth it.
Yes, thank you so much. So we need too much the studies about, for example, denudation and the progenitor cells, also the migration problems. So yes, thank you. This we study about the large animal studies in since children. So we have the long way for the maybe human. Yes, thank you.
Yes, yeah.
Okay. Professor Yunus Aydın, please 2 minutes. And then,
Can I talk?
yeah, 14 minutes,
Oh,
2
okay.
minutes, please.
2 minutes, okay.
Yeah.
I also write a question, but thank you very much, Dr. Kulkarni. This is a very didactic presentation, especially for me, because in the practice, most of the surgeons or advocates of the endoscopic surgeons, they prefer to give the first line treatments for the young kids, EVT. So overall, after listening this lecture, giving the first line treatment, VP shunt is not a big mistake, if I understood well. That's true. Thank you.
I don't think it's so. If the question is, would I consider shunting an infant as the first step a big mistake? Absolutely not. No. You know, I think that there's very good reason to say that no, the ETV is not worth it for the majority of infant hydrocephalus. So I don't think that's wrong at all. And you know, the fact that we have a randomized trial for this group, you know, and that I'm participating in it is because I don't know the answer to that question, right? So I in my mind at all, it is if you want to say right now, all I will do is shunt infants with hydrocephalus, that's a perfectly acceptable answer to me. I think that's completely acceptable. Yeah, I think you typed a question about what is my preference regarding the age and or shunt preference. Was that regarding shunt valve, or did I answer your question?
At the type of the pressure type or flow,
Okay, so
flow type or what?
Right. My general preference is in infants, most of whom present with very large ventricles. I do use a programmable valve. We don't have the gravitational valves here. I think if we did, I might consider that. But I tend to use a programmable valve because I do worry about causing very small slit-like ventricles. So I try to prevent that with, it doesn't always work, but to try to have a programmable valve that will try to prevent that.
Okay. Shandip Kopra, I think he wants to speak. Is that right? Okay. You can turn on your microphone. You can turn on your microphone. Shandip Chopra, you can turn on your microphone.
Please accept investigation. Invite.
You can turn on your microphone.
Okay, can you hear me now?
Yes. Not right now.
Okay. I am Dr. Sandeep Choma, Gangaram Hospital, and I do pediatric neurosurgery. When I started doing ETVs, so I did 6 to 7 ETVs below 6 months, and all failed. So I thought that may be a learning curve for me. So I asked another neurosurgeon, ETV. So I asked another neurosurgeon to do it, and he also failed. Second question is there any criteria of selection of doing ETVs in neonates? Like because the subarachnoid arachnoid villas are immature, and is there any criteria of selecting the subarachnoid space before doing an ETV? That this should be the what we call distance, and all this must be the space between the arachnoid villi and absorption area.
Yeah.
Is there any criteria?
I think what I use is in general, we don't have as much. So you can use the ETV success score to some degree. The problem is that there are not a lot of infants that were used to develop that ETV success score. So it's a little less accurate in that infant group, but it gives you some idea of what the predicted chance of success is. The other problem with the ETV success score is it doesn't include some of the radiographic factors, which I think are important. So I think in general, if you have an aqueductal stenosis, that's a better prognostic factor, higher chance of success. If you've got a thinner floor of the third ventricle, that's a better chance of success. Certainly, it gives you a better chance of doing a good ETV. And then importantly, one of the things I mentioned was to do an MRI with the CIS or Fiesta images in sagittal plane to look at the space in front of the basilar and pons and to see whether there's scar tissue there. That's very important. So I don't do an ETV at all, but certainly I don't do an ETV in infants unless I have that MRI and it shows me that there's not significant scarring there. If there is, which we often see after hemorrhage or after infection, I will not do ETV in that patient.
No, I'm asking, is there any role of subarachnoid space? What do you call the depth or whatever you call it?
I haven't looked at that. I think it may relate to the fact that it's more of a communicating type of hydrocephalus if you have a large subarachnoid space. So one would think that's a poorer prognostic factor.
Okay, thank you.
Thank you, sir. Professor Demirçivi Özer, would you like to make a comment? Professor Özer? Okay. So, Professor Aydın, would you like to add something?
Hello?
Yeah, we can hear.
Yeah, this presentation is very useful for me. I was the head of one of the first children's hospital founded in Ottoman time in Şişli Etfal Hospital. That's why we had lots of cases there. But I know the Uganda experience is useful for especially the poor country. First line treatment and ATV is good choice. But in Turkey, we prefer to do ventriculoperitoneal shunts.
Yeah.
I want to ask you which site you're preferring to put ventriculoperitoneal shunt? Is the Parental or Aqueductal application?
Oh, that's a really good question. Yeah. So traditionally here in Toronto, we've always done sort of an occipital approach. But, this is another randomized trial that our center did, comparing front versus back approach for shunt. Now, statistically, it didn't show a difference, but there was a slight suggestion of benefit for the frontal approach. So as a result of that, even though this trial was not statistically significant, my interpretation was that they're at least the same and maybe frontal's a little bit better. So now I do all mine frontal.
What's your preference? Because of they say sometimes the ventricular catheters tip attached to the choroid plexus and causing the dysfunction, or as some colleagues has the occipital parts. If you don't make the proper adjustment, you go into the unwanted areas, the basal ganglion, like that, and causing complications. In the frontal area, there's little chance to do misplacement.
That's right. Yes, that's why I prefer. My preference is frontal. Yeah.
Yeah. Okay.
Thank
you very much.
Hello. Can I ask a question, ma'am? Hello.
Sure. Please go on.
My rule is I do shunt, BP shunt from occipital till the age of 2 years. Because before that, pericranium is very much attached to the bone. And if you do a frontal burr hole and do a shunt, the shunt is likely to break. So after 2 years, we start making frontal burr holes. And before that, we do a occipital burr hole.
Okay. Thank you, sir.
Yeah, and another contribution I want to make.
I think Professor Aydın Kulkarni, Professor Kulkarni will go to the operation, I think.
Yes, yeah, I'm sorry.
Okay.
Thank you.
Yeah,
Thank you
at
for,
12 o'clock.
I'm really very sorry.
Okay.
Like this.
Okay, go ahead. Thank you, Dr.
Thank you so
Kulkarni.
much.
Really appreciate it.
Thank you.
Bye-bye.
We
Okay.
really appreciate it. Okay. Have a good day.
Thank you.
Thank you.
Thank you once
Bye.
again, Professor Kulkarni. Okay. Bye. Okay. I will stop.